Yes, yes. Good morning, all. So we were discussing about all these techniques, and we were listening to all the techniques that were being discussed down in the hall. So coming back to endoscopic resection techniques, I think we are pushing our limits each year, and some of them we come back to the conventional techniques, but some of them they finally progress to the routine protocols. So one of them is endoscopic submucosal dissection. Yesterday we demonstrated endoscopic full thickness dissection, non-exposure type using a device. Now we are planning to demonstrate ESD, that is endoscopic submucosal dissection, again for a large neuroendocrine tumor, which is close to 15 millimeter in size. And our preliminary evaluation does show that the tumor is reaching till submucosa. And you can see we have done our evaluation, including endoscopy, which shows multiple lesions, but other lesions are very small and can be dealt easily using banding alone or EMR after banding. So this looks like a typical type 1 gastric NET with multiple nodules, multiple small nodules, and sort of atrophic gastric mucosa, if you can see here, with absence of gastric folds. So we plan to take down this larger lesion, which is the largest of all the lesions. If you see, there are smaller nodules as well. This can be easily dealt with using a banding device on an as an outpatient procedure. We don't need to hospitalize for the smaller lesion. They can be easily dealt on follow-up. So what we plan to do, we have already marked around the lesion. This is a submucosally growing lesion. So once we inject, the boundaries are a bit blurred. And the first step is accurately demarcate the lesion so that you know your plane of cutting. I'm again using a needle, and I'll be using a dual knife J for this endoscopic submucosal dissection procedure. I'm using a RPYO3 electrosurgical generator, and here we start the procedure now. So this is the first and very important step, that an adequate bulge should be there. And you can see that this injection is it a sort of dynamic injection. Dynamic injection means as I push, I flex the scope a little up towards the lumen so that the direction of lift is well controlled. And see, these lesions are really vascular lesions, so they bleed. So we have to be cautious, and our hemostasis devices should be in hand so that we can control the bleed as it occurs. Now you see the boundaries are a little more blurred. I'm using a 2 millimeter dual knife J. I think yesterday the participants used triangular tip knife. We don't use triangular tip knife for ESDs. We use them for POEM because it has a long cutting part. So that's why we think that it's probably not safe for performing ESD procedures. So this is the first mucosal incision that we have given towards. So our scope is in retroflex position. I'll just suck out the fluid that we have so that you can have a clearer view. See the vascularity of the lesion. Even the injection site is bleeding. So this is my scope is in retroflex position. You can see the scope. So first I am dissecting in the retroflex position. The difficult part should be dissected first. So I believe that this part of the tumor will be difficult to dissect at the end. So I'm taking down this part first. My aim will be to complete this incision and proceed subsequently. Gradually, we are progressing towards the proximal part of the tumor, step by step. And my aim is to reach into the submucosal plane first. So if you see here, this is the submucosal plane. This is the submucosa, the bluish fibers that you see. These are the submucosal fibers. So my aim is to get to the submucosa first. We keep on injecting. I like the blue color because blue only submucosa is stained with blue color. We may have to do a full thickness resection also. That possibility can't be excluded. It all depends on if the tumor is bit attached to the muscle, then we have to take down for an en bloc resection. We may have to include injectors. So we were discussing yesterday also that NETs which are larger than 1 centimeter, they should always be considered for resection. And I believe endoscopic resection is a safe technique to resect these tumors. For tumors larger than 2 centimeters, surgery is the only choice. And between 1 to 2 centimeter, I think it depends on expertise and what your evaluation shows. If your endoscopic ultrasound shows that it's infiltrating deeper, I think surgery. If it shows that no, it's confined to submucosa, I think we can go ahead with endoscopic resection techniques.
Dr. Zaheer, how deep into the submucosa you go? Is it anywhere, any such thing is there that you need to go?
Pradeep, I didn't get your question. How deep?
Yeah, submucosa, do you do a superficial submucosal dissection or
So
whether?
to begin with, I remain superficial because I'm away from the tumor, and then as I proceed towards the tumor, I go deep so that I can get adequate. So I don't cut through the tumor. So once I go below the tumor, I go deeper. For example, here you see, to begin with, I'm very superficial here. And as I'm going deep, I'm a little more close to the muscle layer. And because the aim is en bloc resection and negative margins. So this is the aim of ESD here. We could have done an EMR or attempted an EMR, but then the chances of en bloc resection are lower, and we may cut through the tumor during EMR because that's a little more uncontrolled technique as compared to ESD, which is a more relatively controlled technique for submucosal lesions. EMR is basically meant to deal with mucosal type of lesions and not submucosal lesions, but we have adapted EMR for submucosal lesions also by incorporating some modifications. Now this part is over and I'll be now starting through this part. I'll inject again using a needle and cut through this part. So at the end, my aim will be to make both the parts meet. So I have done a part of my dissection towards the distal end. Now, my second part of dissection will start from the proximal part.
Dr. Zaheer, you can continue. Meanwhile, we'll go to the OT and see.
Sure.
Before we go on to the thing, actually, we'll have a short history of this patient whom we are planning for an esophagogastrectomy. Can we have the short history, please?
Yes, we can
This
see.
is a 67-year-old female who presented with painless progressive dysphagia to solids, sensation of food getting stuck in mid-chest and regurgitation of food since 1.5 months. There was no history of vomiting, loss of weight, hematemesis, nocturnal cough, or altered bowel habits. On investigating, upper GI endoscopy in September showed a friable nodular occluding lesion in the lower end of esophagus at 33 centimeters from incisors. Biopsy was suggestive of a moderately differentiated squamous cell carcinoma. FDG PET in September showed an FDG avid asymmetrical circumferential wall thickening causing luminal narrowing in the lower end of esophagus for a length of about 4 centimeters. Patient received NaCRT according to the cross protocol. Post NaCRT, symptoms improved and upper GI endoscopy showed just mild circumferential scarring at the lower end of esophagus. And PET-CT
Madam,
showed
down.
minimal residual disease. Patient is planned for transthoracic esophagectomy.
So, very good morning to everybody. As we see, this is a patient which we are planning for a thoraco-laparoscopic esophagectomy. So, can you just focus on the ports? So, this is basically a 3-port surgery. The patient is in prone position and we are operating and having a look to the right thorax. So, are the ports seen? So the
Yes.
first port which we take is with a blunt trocar, and that is usually at the tip of the scapula, which is around the 7th intercostal space. So once that is entered, normally we can put both ports with angulation of the camera under vision. So we usually take another 10 mm port so that the putting of gauze pieces and any such thing can be easily done with one 10 mm and one 5 mm port. So what I'm using is an energy source by Medill company. It's called MESIC. It is looks like a harmonic. It is an ultrasonic shape and looks quite handy to use. What we have done is we had injected 2 ml of ICG dye about 1 hour back into the inguinal nodes of both the inguinal areas. That was done by ultrasound guidance. And usually in 40 minutes, once we switch to the IR mode, we can see the thoracic duct. So can you switch to the...
Yeah, we'll show you 2 modes, actually 2 modes that are currently available. One is the yellow enhancement that has come from Olympus. This is the technology that is recently introduced. Actually, Roy has also used this technology and some other centers in India are also using it. We don't know how much of benefit it has got, but it is, can we switch to the yellow enhancement, please? See the difference between the white light and the yellow enhancement. Here in chest, we may not have much difference, but when we're doing an abdominal surgery, you can see, but still you can see that the sheer contrast or wherever the fat is getting enhanced, it gives a good contrast of the vessels. I hope you can see this actually. Can we switch to white light again? See, that's the difference between white light, yellow enhancement again. So you can see this actually, and especially with whenever you're doing abdominal surgery, pelvic surgery, I think this is one of the modalities that is very useful to change over different modes actually to maybe decrease the amount of blood loss that we do. The second thing now is actually change over to white light now. Now, as Rohit has said, actually we injected the ICG into the inguinal nodes now. Can we switch on to the IR mode?
IR.
Please? And
That is
can you
the
see the thing actually? The
thoracic duct.
Roy, actually, are convinced?
No, sir is not there in the hall. Very
Yeah, I
well
can-
seen.
Yeah.
Thoracic duct.
So you can see that actually the thoracic duct, so you can very clearly make sure that actually we can avoid any injury to the duct. Actually, you can
So-
see the thing coursing against the entire course actually.
So now having used this many a times, we are sure of the anatomy. This is the aorta that is seen, and this is the azygos. So the thoracic duct actually is between the azygos and the aorta. So in case if you're not using an ICG, you should know this landmark that in between these two vascular things is the thoracic duct. But if you're using, it is very well delineated and you can see to it that you don't injure it. Also in patients where probably there has been an injury done or somebody who has a chyle leak, still we can use this technology, identify, and you can clip the thoracic duct there. Put it to yellow mode. Regarding the yellow mode, as sir was saying, the demarcation between the fat and the vessels is very good. Not only that, we've seen in gastrectomies, the node clearance could be done better. So nodes, they could be 1 year, like these, they could be easily identified. Here we cannot see, but whenever there is a lot of fat around and you can't see the nodes with the white light, there sometimes it can be helpful because it will give you a better contrast. So we've started just, the idea is to open the mediastinal pleura. So this, for orientation, this is the pericardium. So patient is in prone position, so the heart is down. And that is the esophagus which we are trying to mobilize. This is the inferior pulmonary ligament which are going to cut now. So this basic has both a fast and a slow mode. This is the slow mode. And then you can use the fast mode. So whenever you need more hemostasis, use the slow mode. So we are going between the pericardium and the esophagus now. You see, we have taken the nodes which are now going to come along with the esophagus. This is where the original tumor was. It was the lower third growth. So all these nodes needs to be cleared. Coming here at the carina, these are the subcarinal nodes. This is the esophagus. And can you switch to normal light? Clean ones. So we can see the right bronchus, which is right in front of you. We are doing the thoracoscopy through the right bronchus. So this is the lower lip of the right bronchus, and this is the upper lip. This is the azygos. This is the most important landmark. Like whenever you enter the right thorax, this is what gives you orientation. If you look at it, this azygos is then going to empty into the superior vena cava. This is the superior vena cava. And here in the supraesophageal area where we had just started the dissection, this is a lymph node. So this is the area where the thoracic duct actually turns, and that is the most common area of injury. So can we get the IR mode? So when we started this dissection, it was very close. Huh? See how close it is. So maybe whenever you know the course, this is the area where we are.
So we can see that actually in white light, we cannot see the duct at all.
Can
Actually,
you put it on white now?
white light now.
You can't make out
We
which
can't
is the
make out
thoracic
the-
duct.
Beautiful.
Green.
Change it to IR mode again.
So you are pretty sure now where it is, and you can avoid injuries. Also, you can be more bold if you know exactly where it is. So in case if you have nodes around, you can do a better clearance, because that gives you that confidence. Okay, your thoracic duct is safe, so you can.
Okay, Rohit, you continue doing the
Yes.
dissection. In the meantime, we'll shift to Dr. Zaheer in the endoscopy room, and then we'll get back to the operating rooms again. Can we shift it to the endoscopy room, please?
Dr. Zaheer, we are in.
Yes, yes, yes. So welcome back. We have completed the circumferential incision here. You can
Sure.
see this is the proximal side where we have. Now I'll be showing you some technique which is very important. I'll suck out some fluid. It's a very vascular lesion. We did encounter a couple of large vessels. We'll encounter more as we dissect deeper inside. Now we'll be using some traction technique, and this traction technique is indigenous because we don't have retractors like when you do laparoscopy. It gets a significant advantage by using retractors, but here we don't have retractors, so we use some traction techniques which will help us in getting below the lesion, and that will be showing now. So this traction is basically a rubber band traction technique, which is very cheap. Yesterday, there was a concern that a costly affair should not be uh, uh, done for lesions which are relatively benign. So this is a very cheap traction technique, which will utilize a rubber band, which is not a special rubber band. It's a simple rubber band that you get when you go for a grocery shopping, and along with some endo clips. So we'll be using two endo clips and we'll be using rubber band. So you can see I'm inside, and here is our lesion. And what I'm going to
IR karo.
So what I'm going to do now is use this rubber band and apply it over the lesion. Yes. Yes. Fine. So this is one end of the traction. Now I'll use the other end. Now I'll use the other end of the rubber band and apply to the opposite gastric wall. And what benefit I'll get is I'll have a good exposure of the submucosa below. So we can do it in a forward view position as well. So what I'll do is I'll catch hold of this rubber band here. I'll catch hold of this rubber band and look for an appropriate position where I'll get a good traction. So I feel somewhere along here. So I have to take care because the rubber band tends to slip away. Fine. So here you can see that we have applied a rubber band, and this will hopefully give us some traction when we are doing subsequent dissection. So you might feel that this traction is inadequate, but as I insufflate, we'll get more and more traction. We can add more clips when we want to increase the traction. So now I can go below the lesion, which is relatively more easily. I'll inject here using a needle. And subsequently, so I am exactly below the tumor right now. So you can see this is the down portion of the tumor. We have the submucosal fibers, which are very well visible here. These are all very vascular bundle of submucosal tissue here. So what we do here is we'll inject some. Okay. And now we'll proceed with our dissection. So these traction techniques, I think they are really helpful when you are dealing with tumors which are on the gravity side. Look, this tumor was more on the posterior wall of the stomach. On the anterior wall, sorry. So in such directions, you do need some sort of traction which can simplify your procedure. You can see how this traction is helping us. You see big vascular bundles. You can see all this charring is due to the bleeding that we encountered.
Zaheer, as you continue doing the dissection, can we just come back to you again?
Sure, sir. Sure, sir.
Yeah.
This is a 57-year-old male who presented with non-specific abdominal pain and bloating since 1 month. On investigating, upper GI endoscopy showed a small subepithelial lesion at the body of the lesser curvature. PET CT scan showed a soft tissue lesion of size 3 × 2.8 centimeters at the lesser curvature, abutting the left lobe of liver. Planned for endo-laparoscopic excision.
Yeah, can we have the video, please? Actually? I hope you can see the laparoscopic view of this. Are you able to see the lap?
Yes, sir.
Yeah. Now, Sanjeev.
Can we have the voice in the auditorium?
You're not able to listen?
No, it's your mic is off, I think.
Yeah, okay. We have this SET along the lesser curve. You can see that. Can you
Yes.
appreciate that?
Yes, sir.
Now, what we're going to do is actually switch between white light and yellow enhancement to show what the difference is. Can we shift to the yellow enhancement, please?
Yellow.
Yeah.
So now you can appreciate the blood vessels very clearly here, and the adipose tissue is
Enhanced.
enhanced. So you can see the blood vessels pretty clearly. So what we'll do is we'll bear the lesser curve approximately around 1.5 centimeter on either sides of the tumor, so that once you continue with your endo-laparoscopic resection, then you'll have a bloodless field and stapling would be easy at the end.
I hope you can see the difference actually. We'll just switch between white light and yellow enhancement. Can we switch
White
to
light?
white light, please?
White light.
See, that is white light. Now, switch over to yellow enhancement, please. That is yellow enhancement. I hope you can appreciate the difference actually. You understand there is a lot of contrast that we get, especially closer to the vessels when you're dissecting, and sometimes the vessels which are not seen during conventional white light dissection could be easily visible. Now, the other thing that we'll do is actually show you another technique. We already have the endoscope inserted in this. Get back to white light, please. Very easy, very easy.
Yeah.
Hold the system. Can we have the endoscopy image also, please? Possible both the images together. You have the endoscopy image now, Shreyas, there?
Yeah, yes, sir. It's on.
No, okay. Now what we'll do is we'll switch off the laparoscopic light. Can you switch off the laparoscopic light, please? Now we can see that actually. Can you appreciate the lesion there now?
Yeah.
See, this is how you take advantage of this. See, that's the lesion along the lesser curve door. That's the margin. Okay, come back
Yeah,
to
right.
again laparoscopic light on. So we keep switching between different modes, and we have the endoscopy continuously during the entire procedure, so that we can aid the laparoscopic surgeon. Sometimes you can do some amount of endoscopic dissection also.
So in this particular case, direct wedge resection with the stapler may not be feasible because there will be a hourglass stomach, and the only options are full thickness excision either by endo-laparoscopic surgery, or you can do a full thickness resection and then suture close the defect primarily. These are the two options. So what we are planning is a endo-laparoscopic
ఎప్పుడు ఇమ్మంటారో కనుక్కొని చెప్పండి.
excision. So even a full thickness resection with the closure of the defect is also another option.
Can we change out to the 11 enhancement, please, again? Yeah. Actually, we had a short survey within our own department to see whether surgeries can be done continuously under 11 enhancement. But I mean, almost about 60-70% of the surgeons feel that using continuous and 11 enhancement is some sort of a strain to the eyes. So intermittently, we have to use this as and when it is required. It is not necessary that you do these procedures continuously under 11 enhancement. There are a lot of other advantages that are coming out with this. Now, I think the industry is working so that actually we can quantify the amount of all this, the brightness of yellowness, and also change the brightness of the enhancement also. It is likely that then I think it becomes very soothing to the eyes subsequently.
Yeah, now the lesser curve is almost bare. Come close. Come in camera. Is almost bare. Another half a centimeter probably, because you'll have to have a good 1.5 centimeters for you to close the defect primarily after you resect the specimen. Come back. Change to white light. See, this pad of fat may not be appreciated. Actually, the whole
Yeah, right.
stomach has to be bared like this, so that
Switch- Yeah,
subsequently
switch to white light.
doing an
yellow enhancement.
endo-laparoscopic approach. Yeah, change
Yellow
to
enhancement.
yellow. See, this area you can see now.
You can
See
say
the
that actually
difference
the fat.
between the yellow and white light. So even these small things are very important, so that when you give a submucosal injection and try to go into the submucosa, you giving a serosal incision, then these come in the way actually. So these small things definitely help in a better outcome for the patient. See, now we have bared the stomach all around. So now we can continue with our endoscopic injection.
You can take this vessel.
And this vessel, in yesterday's case, we had a minimal bleed and we were able to control. That is not an issue, but better to push this down stomach with your left hand. Push it down. So I'll control this vessel. Even if there is a serosal breach, it's not a problem.
Just come.
Yes.
Let me know all this.
Pull the fat away. This one. Pull it away. Yeah, that is
Okay.
yes. So we'll continue with endoscopic submucosal injection now.
Now you can see this. Can we have the endoscopy view, please?
A little.
This is the retroverted view of the thing actually. You can see this entire lesion here. So what I'll do is I'll inject distally first. This intraoperative endoscopy, we have to get used to the thing because it is slightly different from what we do conventional endoscopy procedure because patient is supine, anesthetized, need loud, please. Need loud. Inject. Inject. Sure, enough now. Go. Inject. Yes, stop. Can you appreciate the laparoscopic view also? Actually, see the laparoscopic view also. Read loud. It looks very easy to think, but it is not that very easy to do an endoscopy in the supine position with the patient anesthetized with so many tubes here. Out, read loud. Inject. Stop. Need load. Stop. Anywhere else? Inject. Here. Okay. Need load. Inject. Okay. Stop. Is that okay? Inject?
Yes.
So you can see that actually now we have injected all around the thing actually. Maybe a small push. Read loud. Okay, now it's got all around, no?
Yes.
Stop.
Yes.
So now I can see that actually even on the serosal side, so now it's got a good cushion. Now I'm going to deflate right now. Now, as the dissection goes on the laparoscopic side, we can intermittently insufflate the stomach so that that stretch itself acts as a traction during the procedure.
Hook this. Give me a hook. What are you doing? Pulling it. Take hook. So what we'll do now is again, like we'll give a serosal incision all around the tumor. This is approximately around half a centimeter away.
Now you see the other thing is actually this yellow enhancement, actually the difference between doing the surgery under yellow enhancement and white light will keep switching it actually. See, the edges get slightly enhanced during the procedure. I hope you can appreciate the thing actually. Now we'll just show you the white light. Can we just switch to white light, please? The other thing that happens is whenever we're using thermal energy, the thermal energy somehow it's desiccating and then enhancing the cut edges. You can see this now. Switch over to yellow enhancement, please. I hope you can appreciate that actually. Whenever using thermal energy, that area gets enhanced. This is another very important thing that we have noticed actually whenever we're doing this procedure. So it is almost like having a real contrast when you're doing this procedure. So both the methylene blue and this yellow enhancement seem to be giving us a lot of additional benefit when we are doing this endoscopy procedure, endoscopy laparoscopy procedure. So in between, we keep changing to other light to show you the difference actually.
Gas out. So once you enter the correct plane, then it will be pretty easy. You will encounter such minor bleeds because stomach is a very vascular organ. Come back. Change the hook.
I hope all the surgeons there are convinced actually these are the procedures that we have to learn as surgeons actually. These are the ones which are going to be very useful in practice to avoid major surgical resections basically. And this entire course we are intended to know. That's the reason why there are specific stations in the hands-on workshop to let you see how you can inject submucosal methylene blue. I think all of you should learn this technique so that you can practice this. Okay, what we'll do is, as we continue doing this dissection, we'll come back to you. In the meantime, we'll go back to the endoscopy department to Dr. Zaheer.
Hi, welcome back. So just to show you that we have done almost 80 to 90% of our dissection, you can see how the traction is working. This is the tumor. These are our markings which help us in deciding the part of tumor. We have resected a bit of normal mucosa around as well so that we get a complete resection. And you can see this is the submucosa that is left to be cut. This is the muscle. Muscle is unharmed as of now. And just to show you that how this traction is working, can you appreciate that? That a clip, two clips and a simple rubber band, they are holding the tumor such that they are providing me an easy access to the submucosal plane. Once I have easy access to the submucosal plane, look, this is a very difficult position to do an ESD because my scope is not in a straight position. It's a bent retroflex position. So my scope is retroflexed 180 degrees. So to improve my dissection at this retroflex position, I do need some sort of traction which helps me in delineating these fibers. So yesterday, I think many of you, they did practice peroral endoscopic myotomy and they did get a hack of the electrosurgical knives that we have. Of course, we have been using these knives during surgery as well. So the principle remains the same. This is also submucosal endoscopy, part of submucosal endoscopy, because we are doing these procedures in submucosal plane. As I said, these are very vascular. So you can see the black bravery marks all around the tumor base. And this is the last part. Now I'm using an IT knife, which facilitates the resection on this. And this completes the endoscopic resection. My tumor is safely secured to this clip. You can see that it's hanging down with the clip. I'll just suction some water so that you can have a better view. We need a water jet scope. The reason being we constantly encounter bleeds and to accurately visualize that area. So the minimum requirement for starting an ESD program at your center is a water jet scope. And this is the 190 HQ scope from Olympus. And you can see this tumor is safely secured here. I'm not bothered that it will run away through the pylorus into duodenum because it's secured with a clip here. So I just need to pluck this clip and the tumor is out. So far, there is no muscle injury here. I'll see if there are any major bleeding points. I'll control them and prophylactically coagulate them. And once I do that, we may choose to close this lesion for two reasons. One is that there may be some delayed thermal injury because the excess coagulation that in fact, there was a huge bleed in between that was adequately controlled using the hemostatic forceps. So now with the availability of all these accessories, I think the scope of endoscopy is expanding for these lesions, and we are now resecting lesions which are even approaching up to 2 centimeters in size, provided there is no additional lymph node metastasis, and the EUS shows that this is not muscular deep. I'll also show you the closure technique here, that how this lesion can be closed. We have different type of clips available with us. There is no active bleed so far. The muscle bed can be visualized here. This is the muscle bed, which is intact. And this is, here there was a major bleed, so we had to control using coagulation.
Come here.
If there are any questions from the audience, I'll be happy to answer.
My God. Okay, Zaheer,
Sir,
Zaheer will just come back to the theater and again come back to you when you're doing the thing.
sure, sir.
Okay. If you see the laparoscopic image now we'll just show you how this endoscopy is going to help you actually. Now, if you see this, now this is a deflated stomach now. Can we show it on the upper part?
Hold this, leave.
Now, see, I'll just show you how endoscopy is going to help now. This is a deflated stomach now. Now I am see the margin, the seromuscular. Just keep a watch on the seromuscular incision.
This gets stretched automatically.
Yeah, as I'm insufflating the stomach, see that the seromuscular incision gets separated out. I hope you can understand. See this actually deflating it now, inflating it now. I hope Shreyesh, you can appreciate that. So this is how it helps actually. So it is not that the endoscopist is not doing it during the entire procedure. He constantly working like an assistant we have on the laparoscopic side. The endoscopist is also helping continuously during the entire procedure. And this is an additional traction that we get during this procedure. See that, I'll show you now. See, deflate the thing, the edges come together. Insufflate the stomach again, the edges get separated and you get that amount of traction. So basically, the endoscopic surgeon also continuously has to keep a watch to see how he can help the laparoscopic surgeon do this procedure. See, now it is completely deflated now. Hold it like this or no? Show me here.
Lift your left hand. Suction to me, suction. Suction. So you can see the muzzle layer here and the submucosa very clearly. Come in camera. So it is pretty thick here.
You can see that, yeah, very
Approaching the-
clearly, you can see that. Just change it out to white light. We just show the difference now. White light, please. See now, contrast is not so much. I hope you can appreciate. Now change out to yellow enhancement. Yellow. I hope you can see that actually. See, there is a sheer contrast that is helping us doing this, do this.
Suction, suction. Instrument, take out the instrument. That's take another instrument. Give me a harmonic. You can use even the energy device. Here I'll use the harmonic now because it is a thick muzzle layer. The chances of bleed also are there, and if you are able to clearly identify the plane, then this becomes a very simple procedure without any bleed. So, but you have to be very careful about the mucosa, and the active blood has to be on the serosal side, or else you will injure the mucosa there.
The cushion that is helping you there actually again. So if you are very sure about the planes, you can use this energy source. Again, as Sanjeev told you, the active blade should be away from the mucosa. It should be towards the peritoneal side. See that actually the edges are getting charred and the edges are getting charred. It gives that slight yellow tinge. So now this part, the laparoscopic surgeon does not require any endoscopic assistance. So the stomach is completely deflated now. I hope you can appreciate. Very good. The mucosa is on the opposite side.
So it's very important to give a good amount of submucosal injection, or else it will not be possible. And that is not that easy. As you see, a very good experienced endoscopic like sir should be available.
You know,
see now you can see the mucosa very clearly and the submucosa here. Such a good plane can be clearly seen. Now our aim is to shell out the tumor, leaving the mucosa. Usually at the center of the tumor, most of the times the mucosa will be adherent because of some ulceration, especially in gastrointestinal stromal tumors. So if that is the case, then what we can do is we can hold this. Don't pull. We can fire a stapler across the mucosa, or else the whole tumor also sometimes can be completely shelled out with the mucosa intact. In that case, you need not use a stapler. We can directly suture only the serosal edges together. Come in camera.
As you are getting more and more experience in these procedures, what Sanjeev said is possible that because you have a good cushion on the other side, we keep doing this procedure. At a point where you feel it is absolutely densely adherent and you cannot do any more dissection, then maybe you can use a stapler. Otherwise, you can see this, actually you can shell it out like this.
That is the tumor. And this is the submucosal plane, and mucosa is far away. You can see the vessels there. So if you get a good submucosal plane, then it is, you can use energy source like this and becomes pretty simple, because these blood vessels, if you tackle it with a monopolar, we do it quite often, but there are chances of bleed more than this.
The endoscopic light ekbar. Can we just this is just to show you how the dissection is going on.
Lap light off.
Lap light off. Now, can you
now you
appreciate
can
that actually? I hope you can appreciate that.
Yes, sir.
Yeah.
Thinned out mucosa and submucosa.
Yeah, submucosa and submucosa. Okay. So intermittently we can keep changing this actually to check the thing. Okay, laparoscopic light on, please. Yeah, okay.
So I have a question for Dr. Sanjeev.
Yeah.
So do you think that robotic technology will be more beneficial in such scenarios where there is a very
No.
precise monopolar energy sources available rather than this?
No, yes, definitely. It's a very good question, and it is more precise, and we have tried that out also. It will be more precise than this because both bipolar as well as monopolar in robotic is far superior and it is very precise. So without any energy source, I think with monopolar and bipolar it can be. And the other thing is suturing will be very simple. So probably with robotic, this procedure will become simpler.
And
but the issue is because the robotic arms come from the head and side, endoscopy may be technically difficult.
yes,
That is the only issue there. Or else surgically, that will be superior to laparoscopy. That's what I feel.
I think that will be the other thing, speciality that is going to come in future, Sanjeev. Like you're talking about laparoscopy, endoscopy. It is likely that you talk about robotic and endoscopy procedures tomorrow. It all depends on really, as we get more and more trained into these procedures can be planned and then we can. I hope actually everybody is convinced about this dissection.
yes, sir. Very well appreciated. Nicely demonstrated also. One more question. Tumors in the lesser curvature location, when you denude it, you are actually doing a selective vagotomy kind of thing.
Yeah, but
what is the size tolerance up to where you can denude so that you will not be worried about delayed gastric emptying?
see, usually
the main vessel to the pylorus is avoided here, says actually.
Okay.
Because these small fibers that are coming proximally are the ones which can get damaged here.
The crow's foot is
preserved. The main thing nerve that supplies the pyrolural region is preserved, or that branch is preserved.
So anything beyond that, would you do distal gastrectomy?
Yeah, if you are having any lesion, very good question. If you're having any lesion in the pyloric antrum along the lesser curve, you understand? Then actually, if you have to do an endolaparoscopic procedure, maybe you should have a drainage procedure or a pyloroplasty.
Okay.
see now good adequate dissection is there here. Approximately around 1.5 centimeters of the mucosa is completely bared.
Okay. Sanjeev, we'll just wait for some time. We'll just switch to the endoscopy room and then come back again. Zaheer, you're on.
Hi, welcome back. So this is just to, we talked about endoscopic clips and how to use them for closing a larger defect relatively. So this is an approximately 2 centimeter size defect. Routine clips, if we use in a zipper technique, it may be difficult to close this defect. But then here we are using a loop. You can see the blue loop, and you can see that what we are doing is with this loop, we are threading over or applying at the margins of this defect like this, taking the loop along with it. And finally, once we have applied all the clips, you can see that we have applied, maybe we apply one more clip in the center here. What we'll do next is hold this loop and tighten. So just like a purse string closure, this entire defect will be closed. And this is a very secure closure. And we also use this closure technique if we have a full thickness defect, which means even if there is a muscle defect, this closure technique does work pretty well.
So this is a detachable loop?
So yes, this is a detachable loop, Pradev, and that's the advantage of this. So I'll show you the hook. So this is the portion of, you can see that tumor we have still not taken out. It's still attached with the clip. So this is the part that we catch now with the loop holder, and this will close under vision, under direct vision. And this is likely to close the entire defect and pretty tight closure technique. So this is the hook that you can see. What we need to do is put this hook inside. Sometimes the loop acts funny and may not allow. Now we have got it. And now you see under direct vision, what we are going to see is that how this defect closes completely. So we'll make it the maximum tight possible. You can see that. Yes. Yes, complete tight. Yes. Oh, okay. Release, release. And now is releasing the loop. And now you can see that you can also do a
Very nice. Very nice.
insufflation test to see there's no part of the defect remaining. And we can allow the patient orally by evening or tomorrow morning. So this is called purse string or king closure technique. This loop will fall off in 2 to 3 weeks, and the clips along with the loop will pass through the stools. So now we are going to remove the lesion that we have taken out. Just we need to pluck out one clip. And see, this is the part where the lesion is attached. It's securely attached, so I'm not worried that my lesion will be lost. Yeah. So I just need to catch hold of this clip, bring close to the scope, and just pluck it. The entire lesion along with loop, clip, along with this will be out. So just to show you the lesion. So this is the lesion that we have taken out.
Yeah, very clean. This is the clip you used for the traction, right?
For traction.
Yeah.
So double advantages. Suppose you have a lesion, suppose you are doing a full thickness section, and sometimes the lesion tends to fall into the peritoneum inside. So into the peritoneal cavity. So this traction and it really helps. This is the loop. This is the closure. There is no bleed. This what closure we have done. It also prevents any delayed bleeding. You can check in retroflex position as well, and looks a fairly tight closure to. If you have any questions, I'll be happy to answer.
Yeah, we have a question.
Sorry, can I just ask JR from Singapore? The loop um, um, closure, the hook that you used, was it a proprietary, was it the same as the one that anchored the endo loop, or is this a separate instrument?
The endo loop is, we have two type manufacturers. The endo loop is, one is detachable and the other is non-detachable. The non-detachable is from Olympus. We can also do it with a non-detachable loop, but then it's a bit cumbersome. We need a double channel scope so that from one side we can pass our loop and the other side we can pass the clip. But this loop, I think this is a detachable loop, which is available from another manufacturer, from Leo Med. And the hook, it comes along with the loop. And so this is the loop that we use.
Thank you. Because I think one of the difficulty that we have sometimes is how to re-engage the loop after if we.
Yeah, so that hook is, it comes along with the bunch of loops that you buy. It comes along with that. And it allows you to capture the loop and then finally close it. So very handy. Before that, we were using non-detachable loops where we did not have that hook. And it was a cumbersome technique. But now it's very convenient, comfortable, because you can leave the loop inside and go with your clip and attach clips on all around the margin, lesion margins, the defect margins, and finally grab the loop end and close it.
Thank you very much.
Thank you, Dr. Zaheer, for the wonderful demonstration. We'll go on to the OT side.
Yeah, we back to the theatre. Actually, you can see that actually we further proceeded the dissection. We're trying to shift the mucosa away from the lesion. And then the mucosal tube is almost made, so we can now almost use a stapler to sleeve the mucosa. Show me cross. Come in. Come in. Come in. Yeah.
Hold this, sister. Look like this. So once you reach this stage, then it will be technically more difficult because only the mucosa is hanging here. This is only the mucosal layer. So there
See,
is
what
high
happens,
likely.
yeah. Is suppose if we want actually, then we can inject directly on top of the tumor right now. But sometimes you understand we don't want to do anything to poke the tumor or cause any spillage of the thing. That's the reason why we don't inject anything on to the tumor here. So once we get that cushion mucosa separated, we can sleeve it in. Otherwise, we can always inject some amount of methylene blue on the summit of the lesion endoscopically. Right. Insufflate and see once.
Yeah. Come back. So
We'll
we'll
just-
see whether this is
yeah.
adequate now. See,
Yeah.
all round it has been clearly.
Yeah, now you can see the, can you just?
Yeah. I think we'll just try and apply stapler across the mucosa and see.
Yeah, now you can see
Staple.
that actually.
Well, staple it. Blue. Wait, lay that. Hold it down. Just hold it like this.
So when you're applying the stapler, the stomach should be completely deflated. You cannot afford to insufflate here
Full
actually because it
proper
can
back,
cause
fully
amount
back.
of stretch actually.
Gas disabled. Gas disabled. Proper fully out. Proper out. Out. Show me the proper. Come in, camera in, gentle. See, I'll angulate the stapler a little so that it goes in that direction. Give me my left hand, left hand. And meanwhile, push the stomach to one side and try take the whole tumor away from the mucosa. Come this side, show me the tip. See, this tip may easily perforate the mucosa. All these can happen. Come 1 second. Yes. Now I am able to come this side. One second. Back. Show me on this side. Back. Hold this. Just leave this. Take it to your like that. Left hand, my left hand. See, you have to spend some time here because, as I told you, it's so delicate. Mucosal layer is so delicate. You may just perforate, but come back, camera. One. No, don't pull, don't leave it. Okay. This. Okay. See, I'll staple here. A bit of serous, or even if it comes in the staple line, it doesn't matter.
Close the staple.
I'm just
Yeah.
closing the staple. So if you can see on the endoscopic side, the whole tumor is now within the stapler. One more blue. Okay. A 15-second wait is always important while applying any stapler, you can see the mucosal. Come back, camera back. Broker in, leave it. Leave it out. One more step. Suction. Clean the camera. Clean the scope. No, no, it's not clean. Leave it, hold. Shaky. Leave your hand. Suction. Come back. You can see the sleeve of this mucosa here, nicely stapled. So I'll fire another stapler and complete the mucosal resection. Staple. See, here you have to angulate the stapler about 15 to 30 degrees so that, come back, to more angulation. Come back. Come in, show me on this side. Change the angle. Come back, camera, back. So in this particular case, if we had to fire a stapler before or without doing all this, then the whole stomach will wrap onto the tumor and there will be a significant waste of the anterior and posterior stomach wall leading to a hourglass stomach, a deformed stomach. So I'm firing the final stapler here. Come back.
So now I can insufflate the thing here. See, this is basically to check the thing. There is stomach is getting adequately insufflated. So there is no leak here. There is no bleed on the luminal side here. Nice staple line here. I hope you can appreciate the staple line here.
Yes,
Nice
sir.
staple line here. It's absolutely clean here. Is that okay?
Yes, sir.
Yeah, switch off the laparoscopic light once actually.
Suction.
Lap light off. Yeah, I can see that actually that's the seromuscular incision. That's the staple line there. Everything is intact. Okay?
Okay, sir.
Fine. White light, please. So what we'll do is now Sanjeev will continue to do the seromuscular closure. In the meantime, we'll go to Dr. Rohit. Can we switch over to the other theater, please? And then
So we've taken the azygos. This is between two clips. Looked a little bulky vessel, so we've used one 15 mm clips. Like you can see, this is a 10 mm clip, and this bigger one is the 15 mm hemolog. I'll just show you. Give me a suction, sister. So we have some part of esophagus. Actually, thoracic surgery for esophagus, the most blind spot is the left bronchial area, because the right is in front of you, and post radiation sometimes you have some adhesions there. So we mobilized all around. Yes, sir. Yes, sir. is like, दिखा रहे हो? Shreyash, can you hear?
Yeah, we can hear you, sir. We can see you also.
So these are the lymph nodes which we have cleared and taken.
Yes.
And I'll just show you the subcarinal area, how it has been cleaned. So we have separated the whole thing from the pericardium. The pericardium.
Yeah.
These are the subcarinal nodes which have been separated. This is the right bronchus. This is the clipped azygos. So we actually not used to take azygos in all cases, but whenever there is, you feel that the nodal clearance could be compromised, or maybe in this case the anatomy is such that the esophagus is more towards the left. So if that looks difficult, then we take the azygos like in this case. And now we just have to separate it from the left bronchus. This is the trachea below, and this is the plane. So here we have to be careful. You know, structures like these could be having the RLN, the left-sided RLN. And here how it was close to the thoracic duct, I'll just show. Put a IR mode, Babu, green. So we just got it from here. So you can see it is very close. And no, injuring it, if you are not seeing it this way, is not very surprising. So we just need to get this. That's the trachea. We need to get this esophagus. So this could be because of post-radiation. It doesn't look to be the disease because it's a lower third disease. Suction, sister. So there's some little loose, very minimal from the subcarinal nodal area. That's the left side of the subcarinal nodal area. Normal mode. How many of them? You have to be careful because the lower blade can take the pericardium. Those may be actually the left bronchial nodes. Once we get this little esophageal part which is stuck there, this side, we can even clear those. Give me a suction, sister. Suction. Now you can see we have lifted the esophagus from the trachea below at that level. Here the idea is to remain close to the esophagus as much as possible, especially on the left side, because the left RLN is very close there. Should keep the active blade away from the trachea because the esophagus in the specimen. And actually wanted to save this, but I think if we take that, then make our life easier. Could be the bronchial vessel is what we were suspecting. But that can be taken, it's not a. Clips. I think once we take this, probably we can. Take this. Give me clips. Metal, anything fine. Yeah. Yes, can you hear me?
Yes, 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 we can hear you.
Yeah. We'll take this longitudinal thing. Would be the bronchial, but it's anyway very close to the clips that we have already applied. One more clip. So you will see how close this is to the left bronchus. When we get the whole esophagus to our side. How many? That's what this case, esophagus is little to the left. Give me a suction. Maybe another 5 minutes, we should be able to get the whole esophagus towards our side. Right from the infraesophagus here. Yes, okay. Give me something. These are the fibers which are probably holding. How many? Yeah, we'll just go to Sanjeev and come back. Can you shift it to room 7?
What's in there? Yeah, see, hello?
Yeah, Dr. Sanjeev, you're on.
Yeah. So we have taken a seromuscular layer. Only the serosa has been taken here. So we have sutured it and this is the end result. You can see there is no significant deformity of the stomach now. It appears normal in shape. So we'll be putting a 20 drain and coming out. So you can shift to the other theater.
Thank you, Dr. Sanjeev. Good
Thank you.
presentation.
Thank you so much. Nathan. Go. Suction.
Can you switch to Dr. Rohit's mic? Yeah.
So
We can
now
see that.
we've got the whole esophagus to our side.
Yes.
And this part of this can be actually dissected with the finger when we do the neck.
So that is the
incision.
carina that is seen on the left side of the esophagus now.
Just show you the carine. This is the carina and these are the subcarinal nodes.
Yeah,
which
that is
have
the
been
right
lifted.
bronchus. So from that side also you can see. So it is completely mobilized.
So the advantage is, I don't think you can do these nodal clearance by the initially used procedures like a transhiatal esophagectomy. With the technology advancement, I think any people who need esophagectomy, at least for a malignancy and good node clearance, should get it done, get it removed under vision like this. So that's some nodal tissue which is still stuck there. So we'll get that out. And you can see now the whole esophagus has come to the right. These nodes also we are going to clear. And that is what I was saying, the most difficult area in this is the left bronchus, because that is the one which is the farthest and the most blind area, you can say, unless things get mobilized completely. Give me a suction. So this ooze is from the nodal disease. Even that last bit also we get it out. Give me a suction. We have a cross piece sister inside. This is the carina. Okay. You have a small bead from the nodal disease, and what we can do is just put a gross piece, and in a movement that should get controlled. This is a quite magnified view.
Thank you, Rohit. Thank you so much. Actually,